The public profile of coconut oil projects an image of health and purity, yet in the specific field of clinical lipidology, it is classified as a significant driver of atherogenic risk. While marketing materials frequently highlight the oil for its potential in thermogenesis and endocrine optimization, randomized controlled trials consistently link its intake to elevated cardiovascular risk factors. The persistence of the superfood narrative often relies on the use of surrogate markers, the misclassification of fatty acid types, and the extrapolation of laboratory data to human subjects. We will examine the specific clinical arguments used to defend this oil, the medium-chain triglyceride equivalence, the large particle LDL defense, and the HDL paradox. Accurate risk assessment requires a shift from measuring cholesterol mass to counting absolute apolipoprotein B particles.
A polylipoprotein B, or ApoB, is the structural protein found on the surface of every lipoprotein capable of causing arterial plaque. Analyzing the specific carbon chain kinetics of coconut oil provides the technical resolution required to evaluate its actual metabolic impact. The primary physiological justification for the health claims surrounding coconut oil is its broad classification as a medium-chain triglyceride, or MCT. To evaluate this claim, we must look past the commercial labels and analyze the specific carbon chain lengths of the fatty acids that comprise the oil. This table details the fatty acid profile of coconut oil compared to purified MCT oils. Coconut oil is dominated by lauric acid, a 12-carbon chain labeled C12-0. This single fatty acid represents approximately 45 to 53% of its total composition. True MCTs, specifically those with 8 and 10 carbons, follow a unique metabolic path. They are absorbed rapidly into the portal circulation and proceed directly to the liver for hepatic beta oxidation. This direct portal hepatic pathway is why concentrated MCT preparations are studied for their effects on energy expenditure and satiety. Lauric acid behaves differently. Despite its classification, the 12-carbon C12.0 chain functions more like a long-chain fatty acid. It is largely packaged in 2 kilomicrons and routed through the slower lymphatic system. Trials that show thermogenic benefits typically use purified C8 and C10 oils. These results cannot be directly applied to the C12 dominant profile found in coconut oil. Furthermore, if coconut oil is added to a diet rather than replacing other calories, total energy intake increases. This calorie displacement makes any minor thermogenic effect negligible in a clinical setting. Extrapolating the metabolic effects of short-chain MCTs to whole coconut oil is inaccurate because of its high concentrations of lauric and myristic acids. A common clinical defense is the assertion that coconut oil primarily raises large LDL particles, sometimes called pattern A, which are described as being less harmful. The European Atherosclerosis Society has stated that all low-density lipoproteins are causal in the development of cardiovascular disease. By examining the structural anatomy of these particles, we can see the actual driver of risk. Each individual particle is identified by a single apolipoprotein B molecule on its surface. Regardless of the particle's size or the amount of cholesterol it carries, every atherogenic lipoprotein contains exactly one molecule of ApoB. This makes the total ApoB concentration a direct one-to-one measure of the total number of potentially harmful particles in the blood. Cardiovascular risk scales with the total number of these particles that enter and remain trapped within the arterial wall. Data from discordance analyses show that when cholesterol mass and particle counts disagree, the ApoB count is the more accurate predictor of disease progression. In dietary interventions, substituting coconut oil for unsaturated vegetable oils consistently raises LDL cholesterol levels. When LDL cholesterol rises in these trials, the concentration of causal ApoB particles typically increases in parallel. Attempting to dismiss this rise by focusing on particle size ignores the absolute increase in the total atherogenic ApoB burden. We must also address the fact that coconut oil concurrently raises HDL cholesterol levels alongside LDL. Historical observational studies showed a correlation between high HDL levels and lower cardiovascular risk, which led to the hypothesis that raising HDL would be protective. This timeline shows several major pharmacological trials specifically designed to test that hypothesis by increasing HDL mass. Despite successfully increasing HDL cholesterol, These trials failed to reduce the risk of major vascular events or heart attacks. Genetic studies using Mendelian randomization have further confirmed that naturally occurring high HDL does not consistently protect against heart disease. Current clinical understanding views HDL cholesterol mass as a marker of metabolic status rather than a direct cause of cardiovascular protection. The focus has shifted from the amount of cholesterol in the particle to its function, specifically macrophage cholesterol efflux capacity, or CEC. CEC measures how effectively HDL particles remove cholesterol from cells. A high intake of saturated fat can increase the total mass of HDL without necessarily improving its ability to remove cholesterol. For this reason, the rise in HDL associated with coconut oil consumption does not cancel out the risk posed by the increase in ApoB particles. There are also several peripheral claims regarding coconut oil's role in optimizing thyroid function and testosterone levels. The argument that coconut oil improves thyroid function through butyrate is not supported by its composition. Analysis shows that coconut oil contains negligible amounts of butyric acid. Similarly, for those concerned with testosterone, evidence suggests that managing body fat levels has a far more significant impact on androgen profiles than increasing saturated fat intake. These observations lead to a basic physiological fact. Saturated fatty acids are not essential nutrients for human survival. The body possesses an internal mechanism called de novo lipogenesis, or DNL. This is the process by which the liver and adipose tissue convert excess carbohydrates into saturated fats, primarily palmitate. Through DNL, the body synthesizes all the saturated and monounsaturated fats required for cell signaling and structural integrity without the need for dietary sources. Because the body manufactures its own saturated fat, adding highly concentrated tropical oils to the diet is physiologically redundant. Expanding our view from cellular kinetics to population-level outcomes, we can evaluate hard clinical endpoints, composite cardiovascular events, and all-cause mortality. This summary highlights the concept of replacement specificity, the importance of what is used to replace saturated fats in the diet. Data from the NIH AARP cohort study show that the isocaloric replacement of saturated fats with unsaturated fats is associated with a lower risk of mortality. Conversely, replacing saturated fat with refined carbohydrates does not result in improved outcomes, explaining why generic low-fat diets often fail to show benefits. Major health organizations, including the WHO and the American Heart Association, recommend replacing saturated fats with polyunsaturated and monounsaturated oils. The biochemical evidence remains consistent. The fatty acids in coconut oil increase the atherogenic ApoB burden without offering proven protection against cardiovascular disease. To align with cardiometabolic reality, the evidence supports replacing saturated tropical fats with plant-based unsaturated oils to improve lipid profiles and reduce cardiovascular risk.